I am interested in the hospital bills because I think that they're such a mess, and there's nobody really interested in fixing it either. So let me give you some examples. There was a woman by the name of Sarah Cliff, Kliff. I have been tracking her uh, for a couple of years. She wrote for a publication called Vox, and her style was to focus on ER bills and try to understand why they were what they were, and to expose the soft underbelly of finances from the emergency medicine point of view. Well, anyway, I think one of her last stories for Vox was a story that basically indicated that San Francisco General Hospital, which is the only trauma center in San Francisco, so everybody goes there, is out of network to every insurance company. They took nobody's insurance, none, zero, in terms of a negotiated rate. So what happened is that people who have relatively minor injuries, basically, they trigger the button that says trauma center activation, which opens the cash register and $20,000 pours in. Uh, so they basically their insurance companies of the patients in the trauma center would pay what they thought was fair, and then the patient would get the rest of the bill. Well, what they thought was fair, they would pay $6,000 to $8,000 for a really kind of nothing visit, and then the patients were left with the rest, and these were big numbers. So here we have insured patients who basically come away with huge bills from this trauma center. So that ended basically because the Board of Supervisors in San Francisco got wind of this. They shut it down. They said, we cannot do that anymore. I don't know why it took anybody so long to find this out. But anyway, that was Sarah Cliff's claim to fame a couple of years ago. I found out that she now writes for the New York Times. And she did a paper, an article, August 22nd, 2021, that looked at the variability that occurs when hospitals negotiate with insurance companies what they're going to accept or pay each other, and the fact that it is extraordinarily inconsistent one carrier to the other, and that if you let one carrier see what you contracted with another, they're going to say, hey, your rate for this is better. I want that rate. So it's really kind of hush-hush kind of thing, these numbers. In her research, she created some, there are some examples here. Let me just get to her. So a pregnancy test, the cash price of a pregnancy test was $10. The price to Blue Cross PPO patients in New Jersey for a pregnancy test, the agreed upon price is $93. Ninefold. So we're not talking about 50% more, 25. It's ninefold. MRI cost at Aurora St. Luke's Hospital in Milwaukee $1,093 if you had a United HMO plan, United HMO, versus $4,029 with a United PPO. Same insurance, HMO, PPO, 1,000 versus 4,000. Like how? I need somebody to help me with this. I don't understand it. If you got $1,000 colonoscopy, I would be a little concerned because maybe it's only going to be 8 or 9 inches. I think there's a general rule that you get what you pay for. So if you want to go all the way around, it's going to be $4,000. Knee MRI at Baptist Memorial in Memphis. Knee MRI, $210. One insurance company is getting it for $210. Another is paying $2,800. Massachusetts General Hospital, a knee MRI starts out at $830, 4 times more than the Baptist Memorial Hospital. You could take a private jet to fly down to Baptist and get your thing done and have change left over. Here's one, Erlanger Health in Tennessee. Flu shot, $54 versus $201 for the same shot. There were lots and lots of examples. This is just a quagmire. Her job is to show the underbelly of the medical quote unquote system that we have. And can you imagine trying to fix this? It's not going to happen. It's not going to happen. One of the things that has made this kind of apparent is the requirement that hospitals have their charge master available for normal people. So they don't like that at all, because showing the charge master shows what you've negotiated with various insurance companies. So when one sees the other, they said, "Hey, we want a better deal than you gave us." So the charge master thing is an issue. Most of the hospitals, I think, are just not doing it. There's very little consequence negative if you don't, and so they're just dragging their feet on this. There's a lot of interesting stuff to be seen in their charge masters. Fortunately, these bills really don't matter to me, because I have a thing called socialized medicine, Medicare. Uh, I have a supplement. It works great. I don't think I paid any money except what comes from the Medicare and the supplement for years and years. I think I think the problem with Medicare is it just pays bills. There's no really good effort to kind of narrow variability, et cetera, evidence-based medicine, et cetera. They just pay bills. So this gets me back to the concept that Medicare and Medicaid do not cover the costs of admitting their patients in a hospital. All the administrators say, we can't live on Medicare or Medicaid kind of thing. You would think that they could, because the government must have set the rates in some way so that they could live on it, but they say no. So what happens then is private insurance companies pay a multiple of what Medicare would ask, and that must be the money to help the hospital deal with the lack of funds for Medicare or Medicaid. So private insurance companies, because of the rates that they're paying hospitals, are floating Medicare and Medicaid. And I don't think, that doesn't sound right. I mean, these are private companies. It's not their job to cover for the lack of payment for Medicare or Medicaid. But anyway, that's one of the issues that comes up. So I need somebody to tell me that's not true, that private insurance companies are not underwriting Medicare or Medicaid, because everything I see says they are. The other thing is that when you go to hospital, there's a whole bunch of things to sign. Nobody reads anything. But I got the sense of the power of your signature, because if I just write something on a piece of paper or a computer or form, I can order a $5,000 test on somebody, or an expensive thrombolytic or something like that. And this little signature gives me the right to do that in the setting of my license to practice medicine in California. And all the time that we're doing that, we're trying to help the patient and do the best we can for them. But soon as you put that signature down, out comes the quagmire of all of the prices and all of the discrepancies and all of the unfairnesses. And here's the issue that bothers me. A lot of these bills that get sent out are going to be bills that patients have to pay their own way, thousands of dollars. So you try to help them out, but look, they're suffering because this bill is just not reasonable, or they have no way to pay it. So I feel kind of bad about that, because we know that there's a lot of people who are getting hospital bills that they just cannot afford to pay. And we triggered it all. We didn't want to harm anybody, but we triggered it all. But it's not my fault, but I would like to do something, and I can't do a damn thing to affect hospital bills or this ridiculous insurance system that we have. We can't do a thing about it, except try to do as best as I can on the clinical side. All right, that's it. Send me an email if you want. I'll be happy to correspond with you, wrbucata@gmail.com. Thanks for listening, and bye for now.